Thank you so much for that introduction. I really appreciate it. I'm delighted to be here. I'm going to try to share my screen here in order to get started. Screen. Okay. Okay. Hopefully that's coming through. All right. So this is my presentation that is focused on my dissertation research, which is in progress. So my interest comes out of my experiences as a hospice social worker and a medical social worker in Oregon and then in Michigan, also in California. So I'd like to talk to you a little bit today about medical aid in dying, what's variously been called physician-assisted suicide, medically assisted dying, physician-assisted death. I do want to take a minute to say I'm sorry that I have to do this masked. Hello, sorry, I'm in a shared space that had a COVID case this last week, so we're being very cautious and respectful of one another. So thank you for your understanding. So let's get started. All right. So just a little bit of an overview. I'm going to, and you're going to see this screen again. We'll talk about it a little bit more, this picture in the background. I'm going to first talk about what is medical aid in dying. Not necessarily something everyone knows everything about. You know, as Dr. Edwards said, it's not something that is that folks generally necessarily want to talk about or are comfortable talking about. So I'll give a little general overview of that. I'll also talk about the background and significance. You know, a little bit more about it conceptually and why it's significant to study. The goals of my research. So then I'll talk about, you know, why I think we should study these certain problems and how I think we should study them in order to contribute to the knowledge on medical aid in dying. So we'll talk through the specific aims and design and rationale, and then I'll talk a little bit about some preliminary findings, and I think we'll have some time for questions and discussion. So what is medical aid in dying? So some of you may have heard of medical aid in dying in other places, such as euthanasia, which might fall under this umbrella of medical aid in dying. So there are forms of aid in dying that are legal in Belgium, Netherlands, Luxembourg. They're similar in those. Those are sometimes called the Benelux countries when referring to this. Switzerland, which has become fairly popular for suicide tourism, has been called. There's a movie with a similar name that my mentor, Dr. Krall, actually introduced me to. He's here as well, I believe. Thank you. Austria, New Zealand, actually our neighbor in Canada, right? And then parts of Australia and parts of the United States. So the practices actually vary. So we want to talk about what's actually legal in the United States and where. It's also been decriminalized, but it's yet unregulated. Colombia's actually been doing it for a while. So usually this decriminalization is sometimes like in a court case, and you know, the Supreme Court hears it, decides it's a right, but nothing's kind of happened to organize the policy on it yet. So in the United States, medical aid in dying can be defined, and this is the American Academy of Hospice and Palliative Medicine. This is their board of directors definition. As a physician providing at the patient's request a prescription for a lethal dose of medication that the patient can self-administer, and this is big in the United States, by ingestion, and they have the explicit intention of ending their own life, these folks who use it. Importantly is the self-ingestion. So in the United States, we do not include euthanasia, even voluntary euthanasia. In Canada, you know, just very close by to us, especially in Detroit, they actually do allow euthanasia. It's part of medical aid in dying. There's an option for self-ingestion, and there is an option, and there's also an option to have a physician, or actually a nurse practitioner is allowed to do it in Canada, administer the medication for you or for the patient. So in the United States, we're very, very, very big on all the states request or require that you ingest it yourself. You also must be 18 years of age. This is not true everywhere. Sometimes this surprises folks. The Netherlands have for a long time been, not a long time, but it's a long time if you think about it, the practice, and a lot of people are, you know, a little jarred by it, that children may choose voluntary active euthanasia. That's a bioethics term. So voluntary meaning the person chooses it, active meaning something is done, so a medication is administered rather than something is not done, passive euthanasia. So there are some places in which children can choose this, but the United States is not one of those places, so you must be 18 years of age, and you must also be capable of making health decisions. This has been, this part specifically has been contentious in a lot of ways, but specifically for dementia patients who have been unable to use medical aid in dying because for their dementia is frequently not very quickly terminal. And so for patients who want to use it, who need to be in this usually like the 6-month window where their illness will take them, if it naturally progresses within 6 months, they're not usually eligible for that, because once they get to that 6-month point, they're no longer capable of making health decisions. There was a popular book actually that came out recently by a woman named Amy Bloom, who is also a former social worker, called In Love, where she writes about taking her husband, who was diagnosed with dementia, to Switzerland using the organization there called Dignitas. So it looks very interesting. I haven't read it yet, it just came out. So here in the United States, you have to do it yourself if you want it. You have to be able to self-ingest. You must be 18 years of age. You must be capable of making health decisions. And you also must have a terminal illness. So there are some places who allow folks with mental illness, or just determine it's persistent suffering or some sort of other verbiage. So in the United States, it's very important that you have that terminal diagnosis. So where is it legal? Just briefly, let's talk about that. So a Supreme Court decision in the late 90s decided that it is not a part of the Constitution. It's not a constitutional right, the right to die, the right to have someone help you end your life, even if you are terminally ill. So it is legal in just a few places. Oregon was the first. Washington, it is also legal. So these states that you see that are this turquoise color is where it is legal. And this is from Compassionate Choices. This is an advocacy organization that advocates to legalize medical aid dying across the United States. California, Montana, Colorado, Vermont, Maine, New Jersey, Hawaii, and now also in Washington, D.C. And so you can see that there are some states. Actually, those little yellow circles are where Compassionate Choices have that group has active efforts to legalize it. And those dark blue states like Nevada, and Arizona, and North Dakota, these here are ones that actually have some sort of legalization process going right now, that there are efforts to legalize medical aid in dying. So this issue is pertinent to a lot of folks. A lot of clinicians, I think it's hard to remember, to remind ourselves that, no matter what we choose, in the end, we're all headed to the same place. And so even if we think that these things are not relevant to us, or maybe they're not relevant because we don't live in a certain state, there's been lots of folks who wanted to move somewhere in order to utilize things. So, and I guess I should say right now also that, that it's not always called medical aid in dying, that physician-assisted suicide is another one that's commonly referred to, but medical aid in dying is sort of a choice, like other linguistic, cultural things that, you know, has come to be the more neutral choice that doesn't involve physicians too much in the verbiage, and then also doesn't conflate it with other forms of suicide. So let's talk a little bit about who uses medical aid in dying. Now, I've chosen to use the data coming out of California. So the bills are often called different things in different places. This is, California calls theirs the End of Life Option Act. I believe there have been since 2016, but this is their 2020 data report. And I've chosen just a couple different variables to report on from California. I chose California because it's a rather large state, because it's a fairly diverse state, and also, but also because the numbers seem to mimic other places. So we have lots of data from Oregon for the many years, I think about 25 years now that it's been legal in Oregon, who call it death with dignity. So I wanted to use some fairly more recent data, and this is just from the 1 year in California. It's also important to know that these numbers apply to folks who actually used the medication. So there's a lot of folks who have conversations with their physicians about medical aid in dying. And then there's some folks of those who start the process of actually seeking out medical aid in dying and trying to request the medications. And fill the prescriptions and see the second doctor. And then there's even less people who finish that process and get the medication. And then there's even less people who actually use the medication. So it's actually pretty common for folks, about a third to even more in some states, in some cases, to get the medication to end their life and then end up never using it, either because they got too sick to do it, to self-ingest, or because they decided they didn't need it. So all these numbers are from folks who actually use the medication, and you can see from the end that this is only 435 people for that year, and I think that it came out to around 10,000 or 15 and 10,000 in every 10,000 deaths. So cancer, obviously a big underlying disease process, right? 71% of the folks who use this had cancer. The median age is 74, but that range is huge, right? 27 all the way up to 107. And then the gender pretty much split 50-50. However, it looks slightly more females than males. And then let's go on to the next slide. Race and ethnicity. Huge portion of folks who use this are white. It came out to about 87%. I think it's closer to 88% when you look at those stats from the data sheet. And then I did put in, the various levels of education that are reported by California, but the donut on the outside here, this orange and red section, shows you that over 75% of those folks are college educated who end up using the medication. So let's talk a little bit more about the background and significance. So lots of advocates of medical aid in dying, people who have been trying to get it legalized, have been talking about how it offers autonomy for many years. This is sort of, and they don't always use autonomy, sometimes it's choice, but this is common, and Gansman notes this in his research in Canada of advocates who are fighting for medical aid in dying. So here I want to let you guys know that I'm using the concept, let you folks know that I'm using the concept of autonomy as defined sort of in the bioethics medical realm by Beauchamp and Childress. They have a text that's commonly used for bioethics and ethical education that is defines it as normal choosers who act intentionally and without control, controlling influences that determine their action. So autonomous individuals as normal choosers who are acting with intention and that don't have something controlling them, having influences controlling or determining their actions. So later when we talk about, a little later when we talk about autonomy concepts, you can think about some of those words. For instance, self-determination is something that comes up, independence is something that comes up, control is something that comes up, that has some connections to this idea of autonomy. Disability advocates have actually, though, long been concerned about this limiting in autonomy and the potential for abuse, coercion, and options that are limited. So not all of the disability community, some of the disability communities or disability advocacy groups are for medical aid in dying. However, many have been concerned about the potential for folks to be coerced into dying earlier than they want to because they don't want to be a burden on their family. And they've actually also been concerned about insurances eventually not offering care and paying for care in favor of medical aid in dying, which might be cheaper. Interestingly, this is also a fear that physicians, even those who support medical aid in dying, have also been concerned about, which I think says a little bit something about our health system and payment system and how it's set up and our trust in it. So, in contrast to these fears from some of the disability advocates, recent research about medical aid in dying as a treatment option, specifically some ethnographic work from Mara Bookbinder in Vermont as they were getting started. I think theirs passed in 2013. Anyway, so Dr. Bookbinder saw that actually there were some barriers to access. So, we think of it as sort of expanding autonomy, and then disability advocates are concerned about it, limiting it. But we find that in practice, there might be some concerns about access and the ability to choose, and what ethical responsibility there is for physicians to inform folks of this. She found that there were some problems with, education, people not knowing what they don't know. People didn't know about it. People didn't know where to go. Medications are too expensive and not paid for by insurances. You simply can't find a doctor who's willing to participate, or the doctor isn't required. Now in Canada, they're required to forward you to another doctor, but not required. It's a conscientious objection clause that sort of allows physicians not to participate in this if they don't want to, or if they have, a conscientious objection. However, in most of the states, you're not required to refer them to somebody else so that they can get that service, or they can talk to somebody else about it. So Bookbinder and her colleagues were actually finding that, like other treatments in the United States, there are barriers to accessing it. And so this concept of autonomy, as you can see, this idea of being a chooser or acting with intention, and especially without controlling influences that determine your actions, is really central to this issue of medical aid in dying in many ways. So there is research from other countries that, since we do have other countries that are participating in forms of medical aid in dying, but there are a lot of differences, cultural differences amongst, this is largely Western, predominantly white countries that have legalized medical aid in dying or some form of it. But they are not all the same, and especially in practice. For instance, like I said, in Canada, a nurse practitioner or a physician may administer it as voluntary active euthanasia, meaning they provide the medication that causes death rather than the person themselves. And in the US, that's like sort of untouchable. We're all afraid of the slippery slope that's going to lead to that. So it's very important, first of all, to have more research in the US generally. Research currently in the US finds that physicians' attitudes and potential practices on physician attitudes and potential practices usually uses survey methodology. There are some decent interviews, not all of them, some of them from folks in the US, from other, folks in other places, which, complicates the information we have on the United States. But this survey methodology is great for, understanding sort of a scope, but the depth is a little limited. And so with the limited extant research we have, we see that physicians themselves are increasingly supporting medical aid in dying. More and more are saying that they think it should be available to folks. But many of those physicians are not likely to practice it due to legal and ethical concerns, litigation concerns, concerns about handling ethical dilemmas as they occur. And they all identify a need for more training. In Canada, actually, this is a similar issue, identifying a need for more training. We don't have enough information. And then finally, the research here shows, some of the research here shows that physicians who maybe aren't necessarily practicing medical aid in dying right now, but physicians in general who were surveyed on it, perceived that patients would seek medical aid in dying because they were afraid of pain or in order to avoid pain and suffering at the end of life. But from Oregon, from 25 years of cumulative data in Oregon, the number one reason identified by over 90% of people is the fearing the loss of autonomy. And so I want to bring it back actually to social work and anthropology. Why is this a social work and anthropology, or in our departments we call us we're swans. Excuse me. So why is this a social work and anthropology issue? Well, social work can be a little easy to kind of an easy jump, I think. Not really a jump at all, an easy walk. So many social workers are faced with medical aid and dying conversations, even in states where it's not legal. So in the late 90s, a researcher named Ellen CK did some surveys with social workers in southern states, hospital social workers, not hospice, hospital social workers in southern states, and found that I think about 25% of them, maybe almost a quarter of them, were having conversations with patients that patients had brought this up to them. And this was in the late 90s when Oregon was just legalizing it, around, yes, the Dr. Kevorkian era that time. But especially interesting that these social workers were from the South, where we have a lot less association with, and you can kind of see, if I go back to that slide where we look at the map, there's kind of this dead zone here in, what you may call the South, or, maybe Bible Belt or whatever. So these were social workers, or she works in Alabama, it wasn't disclosed, could have been probably somewhere around here, Texas, Alabama, in there, Louisiana, that were having conversations. And, so, 1 in 4, that's a lot of folks that are having conversations about this, this thing that is, not legal. But they still have to navigate this with patients. So this is a social work ethics concern, and an ethics concern for other clinicians. So I'm hoping that this work can contribute in multiple areas. But that social work ethic of self-determination is actually very similar and so self-determination, enhancing and upholding self-determination for our clients in social work is important. But in medical ethics, it's respecting autonomy, right? And so these are very close. And then Hugman identified that, or opined that ethics in social work should be understood as the fabric of social life. So as something that is happening, that occurs. And so when we get to a little bit more on my methods and what I'm doing, it makes a little more sense, but something, not that these are imagined vignettes that we created or frameworks that we're talking about in classroom, but actual situations, which is what I'm essentially trying to collect in a lot of ways. In anthropology, this work really follows Michael Taussig's call for research that explores the clinical construction of reality versus the cultural construction of clinical reality. So, and looking at how the clinic and the medical profession, something called medical culture, constructs reality therein, and the power issues that we know are related to that profession. That's a very prestigious profession in the States in a lot of ways. Although the last few years it's been a little a little more tumultuous, and how the clinic constructs the reality, rather than thinking of just something called American medicine as feeling pressure from these outside, like, greater cultural forces and being shaped in that way. So by interviewing the physicians and getting their perspectives, rather than interviewing the people, who, and which is, by the way, very difficult to interview people who are seeking medical aid and dying. It's very difficult to find them. And then the gatekeepers, they understandably, as when I was a social worker, also would have wanted to want to protect their clients. It's a very personal, decision, right? And that, listen to autonomy coming out in me when I say it, it's a very personal decision. So I follow this assertion that, that we should be asking the clinic and not necessarily the culture to, whom there's often less power held within, the every person. And I also am using physician narratives to understand training and enculturation and medicine as a set of social practices and cultural values. So I follow the work of Good, Delvecchio Good, and Pollock, who are looking to physician narratives to understand not just how physicians are shaped by training and enculturation, but then how also they shape medicine as a set of social practices. And finally, some work on death, autonomy, and choice. So, my work in medical aid and dying joins some other anthropologists who have worked on medical aid and dying, but also death practices, autonomy, which is a little less addressed in social work, a little bit in in anthropology, a little bit more in the crossover of anthropology and medicine. And also the idea of choice, which hasn't been discussed as much recently in anthropology, but in medical anthropology, there's some really good work on it from the early aughts. And then a dear, brilliant researcher who we just recently lost, Sharon Kaufman, has done much wonderful anthropology on how the hospital and how professions within it, how that constructs the way we look at death in the United States and our culture. So, what are the goals of my research? So I hope to provide valuable data on physician practices and beliefs about medical aid and dying. So this, in general, there's a dearth. It hasn't been legal for a really long time. It keeps being legal in other places, keep adding on. Sometimes there's little changes, different ways that it's put into practice. And then also clinical manifestations of autonomy. So what it actually looks like. What does autonomy look like? Is it autonomy? Is it something else? What's being described? What's out there? When we're talking about this contentious practice that, some have said exemplifies autonomy or is the ultimate realization of it. And then also data on ethical views and practices in non-normative death situations. So, if you're thinking about, 10 or 15 people in every 10,000 deaths in California, this is clearly not a normal death situation to choose medical aid and dying. But, I also hope that exploring autonomy in this practice could also illuminate research paths or have some lessons for the other side of these non-normative death situations, for instance, ones that also involve autonomy, but where folks are choosing things such as incredibly, incredible life prolonging measures in the face of really bad prognoses. So when folks are told, there's nothing more that we can do, and they say, well, we still want you to do everything. So I'm hoping that, my work can help illuminate some of those paths or contribute to a longer research agenda for things like that for me specifically, but also in general. I'm also interested, and I hope that it provides valuable data on the continuity of ethical concepts across settings. So because I was a practicing social worker and also teaching ethics to social workers, future social workers in practice classes, I'm really interested in and think we need more on this notion of ethics as something that we write about, ethics as something that we practice or things that happen in like in a situation in the actual space of it. And then ethics is something that we talk about later. And so this makes a little bit more sense when we talk about, we'll talk about the different phases of my research and how I'm interested in what ethics look like, and especially ethics concepts across these, maybe settings is the wrong word, maybe modes of communication. And then I think that we'll probably get a little information on we already are getting information on the possible barriers to ethical and quality end-of-life care, so especially in medical aid and dying. And we'll talk a little bit more about that later. So I'm really hoping that this research is part of establishing a rich foundation to inform training gaps and clinical ethics and further research on care for the dying. So I'm going to skip these specific aims. I'm going to go back to them as need be. And I'm just going to talk to you a little bit about my design and rationale. Pardon me. I'm going to talk just a little bit about my design and rationale and what I'm doing, how I plan to address these, or how I am addressing these problems, some of the problems that I italicized earlier and talked about. So one of the things I'm doing right now is doing a thematic analysis of some editorials, opinions, and commentaries in top medical journals. So the idea about this is that it provides Catherine Reisman, a narrative writer, author, and researcher, and wrote the book on it. Might say this provides a basis for local context of production and circulating discourses that influence what can be narrated and how. So essentially, I'm looking at these op-eds, for lack of a better word, just an all-encompassing word, in medical journals that are usually written by physicians to see what's the scope, what can people say about this? What are physicians saying about this? What are the arguments that are in writing? What are editorials? What's being approved? What's going on out there? What limits, what delimits? And then, when I get to interviews, can compare that also with what isn't being said or isn't allowed to be said necessarily, or what's being said in spite of that. And then this overlaps a bit with the physician interviews, as I've also started working on physician interviews. And one important piece of this is that I'm doing actually 2 interviews per physician. So first I'm doing a narrative interview, which is where I allow the physician to tell me about their experiences with medical aid and dying. So, I say something, my prompt is something simple like, tell me about a case of medical aid and dying. Tell me about a patient that you helped. And then I just let them go. And so I hear from them what's important about that, what they want, the story that they want to tell, that they want to put out in the world, or maybe not that they want to put out in the world, but just comes out. So it's a little deeper notion of narrative. But essentially, I'm looking for a base that's driven by that person that I'm interviewing, and then obviously also the influences on them. But I'm just sort of letting them go. And so let me go. Oh, does it let me go back? Should let me go back. Okay. So in the first one, the op-eds, I'm looking for those written ethical positions, beliefs, recommendations. And 2 through 4 aims is what I'm addressing with these interviews. This first interview, where I'm looking for these aid and dying concepts, beliefs, values, dilemmas, practices, and then also the autonomy concepts, ideals, concerns. In the narrative, I'm just kind of saying, are these here? Where are these? What are folks telling me? And the second interview gives me an opportunity to follow up, an opportunity to ask directly about some of the concepts that they either included or didn't include, and to sort of explore, what came out, what was new that I, hadn't thought of or hadn't imagined. But then also, these concepts that we'll talk about later, these related like self-determination or being a master of one's own fate, and other things like that. And so I want to compare and contrast these data with one another, like the interviews with the interviews, but then also like thinking about, and this isn't really like we're not really looking for like, you know, this isn't something to be generalizable, but, you know, are there differences between doctors in New Jersey or California, doctors who have been practicing for 20 years and doctors who have only seen one person or two people? And so that comparative piece in AIM-4, I hope will be answered in part, at least, or provide valuable and interesting data from the narratives, and then that follow-up semi-structured interview where I can address things more in depth. The other piece of that is, you know, and narrative isn't exactly designed to expose this, but, you know, narrative elicitation, it may or may not be things that are cognitively available, that we don't always, when we're telling a story, say, I'm going to tell this in the story, or I'm going to say this in the story. And so the idea behind, you know, having a narrative and then following up with that semi-structured discussion is that you might see things in the narrative that you're not going to hear when you say, ask somebody, you know, well, what do you think about choice or autonomy? They might say completely different things. That in and of itself says something interesting. And the final piece is this piece about cultural and educational milieu of medically and dying practicing physicians, in which I'm really trying to get this sort of ethnographic idea of what goes into, you know, what surrounds physicians, what is created by, you know, it could be media, movies, it could be trainings, it could be conferences, it could be a person that a few participants find was inspiring. It could be, you know, an agency website or an organization website, a listserv, as it were, is one of the things that have come up. And so there are many ways to sort of observe and immerse myself in what physicians experience surrounding medical aid and dying, and how that affects or how it's affected by their beliefs, views, and ideals surrounding that. So really quick, let's talk about some preliminary findings. Autonomy concepts, so some things that have already come up in interviews. People who are seeking medical aid and dying, calling them master of his own fate, fiercely independent, a type A personality. And these are all things that are, you know, type A personality in this context was like sort of a determinism, you know, so this person had the ability they knew what they wanted, making decisions. And so these are these like labels that are sort of related to these autonomy concepts that I'm really interested in. And the interesting part about that specifically is that there's also a lot in these interviews about relations and relationality and sociality and these connections, these kin connections and care connections, where these folks aren't able to really make this process happen as one person. And there's all these family members involved, or there's someone supporting them, or, you know, they have hospice involved, or not, because sometimes hospice won't be involved, which is kind of a longer discussion. Religious hospices sometimes won't be involved. That's another conscientious objection that gets, you know, we're religious hospital systems. So understanding, like, you know, the actual setting of, you know, delivering autonomy in this highly relational context, and talking about autonomy, you know, that these folks are fiercely independent or a master of their own fate. What sort of, you know, thinking forward, you're thinking about sort of what implications does that have for professions that place such a high premium on these individual choosers, and, you know, what of relational autonomy, which has been offered by some. So there's just some things I'm thinking about right now. And then also barriers. We've already heard some talk about barriers, finding a pharmacy that's participating, affording medications, finding a doctor that's participating, knowing what organizations to get help from, or even that there are organizations that help. And then also cognition, you know, for folks who don't have dementia per se diagnosis. So Parkinson's sometimes has more or less dementia qualities to it. Who's appropriate and when are they appropriate, and how how are doctors interpreting that? Is that a barrier, or is it not a barrier for some? Because it seems like, similar to other ethical issues, it seems to be sort of variously interpreted in practice from the little bit of information that I have thus far, which is really interesting. I also wanted to say that this photo here that I've included, this is a patient who actually used medical aid in dying, and this is some loved ones that are gathered around them when they actually used it, placing their hands on them. So I wanted to use that to sort of sum up my talk, and thank you all so much for attending, for your time and your attention during my talk, my long-winded talk, and I hope that we have time for some questions and discussion.
Absolutely. Thank you so much. If you have a question or comment, feel free to raise your hand using the reaction button on the lower right-hand side, or place your comment or question in the chat box.
There is a question already in the chat box that Caitlyn might want to address. It's from Kathleen. It says, could you comment on how your research may be applied practically to help to guide informed practice by healthcare workers in the field, and how the U.S. experience with MIAD may or may not be translatable?
Yeah. So this, I mean, giving an example, sort of depends on findings that I don't really have yet. But one of the things, in terms of thinking with what's already happening is really what I was talking about in terms of autonomy. And I know that lots of physicians, practicing physicians, or it's my understanding that lots of practicing physicians really understand that autonomy is not, just this one person in a bubble. But the fact that we place so much in, and I'm not actually familiar with nursing ethics as much, but that we place so much emphasis on an autonomy that, talks about being free from pressures, yet we have these folks who are not completely dependent, but dependent in many ways on family and all these relational, these sort of webs of like connection and ways that, people are picking up the prescription for them. They need somebody to get them to the doctor. They need, they need a caregiver to help them mix the actual medications. Doctors and organizations, hospices usually will not be involved in mixing the medication that has to be taken for that. So when we're thinking about, what could come out of this that could apply them, is like this sort of closing maybe of this discussion of what ethics is and what it actually looks like what it looks like in situations, and how we can sort of limit the amount that we talk about things in the hypothetical or in the ether, and like instead talk about some real situations and how murky they can actually be. And so I'm hoping that that can help, some of my findings can help guide that. That's just one possibility. I can't talk about findings I don't really have yet. But it's my suspicion that might be, realizations and actual what happens in autonomy might be one of those things that, could be really helpful. Thinking more about barriers and what barriers actually look like, getting actual like situations of, okay, folks can't afford the medication. Like in some cases, one practitioner brought up like, I think they said Good Samaritans, I can't remember, folks who have like paid for medications for people, or agencies that have given scholarships or grants for these things. So publicizing a little bit more how these, I don't know if publicizing is the right word, but understanding how these barriers not only exist, but are addressed. So, affording medication isn't just whether or not you can afford medication, like, unfortunately, there's no, that I know of, federal data on this because it's not federally regulated. And even in Canada, they actually, I've heard, have some pretty serious issues with, regulating and aggregating the data from all the different provinces. So that's another way, thinking about the barriers and getting some of that nitty gritty. It's not necessarily a way that we can say, oh, this is what'll happen in every case, but it's a way that we can continue research and start conversations with practitioners to bring up, like I said, how complicated some of these situations are. So in terms of beyond the communities I'm recruiting from, my physicians are, and this is a great question, my physicians so far that I'm recruiting have been from all over the United States. So, insofar as like, I'm trying to think if I don't think I have anyone specifically from Washington, DC. So there will be some ways in which, there are some ways in which, especially implementation has been, better or worse in some places, and that, some Vermont, it seems like they just kind of said, okay, doctors, good luck with that, in a lot of ways in terms of interpreting this. Whereas other places have gone up, have said, here's this information about what to do in this in these situations. Here's your checklist or whatever. So it won't be direct. It won't necessarily be translatable in terms of like specific policy, maybe necessarily, but the concepts I'm talking about are a lot in a lot of ways probably. And the ones that I look to and I'm trying to think about are really in a lot of ways broadly interpreted across the United States, I think. Although I think it is a great point that there could be some really interesting differences, in terms of like how they're doing things in Hawaii instead of, versus.
Could I just interject for a second? But I was kind of going there, and again, thank you so much for your talk, and it's nice to see you out there. But it seems like it is a very individualistic sort of approach to living and dying that might not be shared by all different ways, of very kind of Western way of looking at things. It might not be the way that many people view themselves in relation to families, and what does autonomy even mean when you have, decisions made in more like a group setting. So that's what I was kind of wondering, how much you're going to encounter, you're probably going to encounter that a lot because of the way that this is being conducted, but there may be really important groups of people that might feel under pressure almost to adhere to these kind of liberal views of what does it mean to be a person in the world. And I don't know if you've read that book, The Spirit Ambulance, about death and dying in Thailand. But there's an American physician who goes elsewhere, and he, having trained in the US, he has to really change his whole way of thinking about what does it mean to be a person, in addition to what does it mean to live and die.
Yeah.
And I think there might be some elements of that out there in our country as well. I don't know if you're going to encounter that or not, but it sure would be interesting.
So I don't know that I will encounter it researching this, but this is sort of what I mean. And I should have read that book. I wish I could say, yes, I've read that book, because Dr. Stonington is on my committee, actually. Scott Stonington wrote Spirit Ambulance. He's on my committee.
Well, you can watch the video of his presentation if you don't have time for the book.
Yeah, I certainly will not tell him I did that. So I'm actually hoping, I don't know about outside of the US itself, but I'm actually hoping that for folks that are not part of what might be termed like majority cultural values, and that this research can be helpful in terms of thinking of autonomy through, and actually Scott Stonington as one of the few anthropologists who's writing a little bit about this as a medical anthropologist. He writes an article called "Whose Autonomy?" And he's not even like thinking, he's not even necessarily talking about folks who are, not, waspy white folks. He's talking about those folks too. And this is essentially this, complicating autonomy, not just for folks who aren't part of, Western origins or don't identify with that or hold different cultural values, but also even for the folks who do, and how complicated that relationship actually can be. How, he writes about how this man's desire for not taking medication is actually also influenced by his wife, and how this, how this process unfurls. So what I'm hoping is that in complicating concepts like autonomy and showing how much there is behind it, that we can broaden our views so that we're not closing it down to exclude folks when we're talking about it. Like when I talked about how ethical concepts move, like from practice to discussion to actually how we're reviewing them later, right? And so that's my hope. My hope is, complicating ethical concepts and talking about them how they exist, rather than, in some sort of conceptualization ether, then will then help folks who don't necessarily, subscribe to those concepts.
Thank you.
No, there's other folks with their hand up. Sorry.
Michael, I saw your comment in the chat. Did you want to ask your question?
Sure. Well, thank you. Yeah. Thanks, Caitlyn. That was really excellent. My question is about euthanasia. You mentioned that in the US it is not allowed, but it is in Canada. And talking about the US, you mentioned the slippery slope. I'm not sure if you're referring to what the Nazis did and whatever, but why do you think it is not allowed in the US and it is in Canada?
That's a good question. I originally wanted to answer that question in my research in like an earlier prospectus, but it got really big. I think that, it's one of my points about, how different it is to say, there's so many similarities between the US and Canada, and then like, stark differences like that, where like, most folks don't even use the self-ingestion method, and practitioners don't really even want them to, because they're afraid of complications in Canada. I don't know if it's related to like possibly a litigiousness, a litigation. I don't know if that's more common, and the fears of that are more common in the US, not just because we're more litigious than Canada, so to speak, but because of how different our healthcare system is, and that we are very individual focused in our healthcare system, and that if you can't pay for it, or you're not in abject poverty, you certainly can't get it. Because we've moved back in that again. So it might have to in part do with how we view doctors' responsibilities to folks, and that it may be slightly different because having to do with those health systems. It may be related to also histories. We had Dr. Kevorkian happened, and it was a big deal for especially folks in Michigan. That's my suspicion is that that's why we don't have a Compassion and Choices chapter here. But there are also all these historical things that happened. There was a euthanasia bill in Ohio in 1908, a long time ago, and so it's been discussed variously, but I couldn't tell you. The slippery slope is that danger that will slide toward euthanasia, and that it'll become but maybe it's part of what disability advocates are afraid of, and that when you have a healthcare system that's so focused on who gets paid and when, rather than a universal healthcare system, that the slippery slope descends into, we remember the death panels. So I don't know. Is the short answer, but that's the long answer.
Yeah. Well, thank you.
Yeah. Do we have time for Edward's question? I think he's had his hand up for a long time.
Yeah, thank you very much for this fascinating talk. And I was laughing during some of your conversation with Kathleen, because she touched on tons of stuff. And then you said that Dr. Stonington's on your committee, and I know Dr. Stonington, and actually the circles that you and I swing through are similar. I worked for Dr. Sankar for many years. I graduated from the Wayne State program, but now I'm teaching a medical ethics course at Oakland, and I touch on all of this, and I use Scott's Autonomy, Whose Autonomy article is fascinating. It's punchy, it's short, and it really helps students kind of get it. What I really appreciated, I think I would hope you never lose it, is this idea of unsettling the autonomy concept in a way that leaves room. Like, to me, and I always remember Mark Laborski mentioning about culture, and the word culture gets used so much that it ends up losing meaning. I think autonomy fits that category. It's just a knee-jerk reaction, and the sort of complexity gets flattened down to it's my choice, when in reality it's often an illusion. Most of us don't make our own choices, and 100%. There's always someone else involved. To get at some of that, or to kind of get to my question, I would love to have time to talk more at some point, but have you considered interviewing, or have you interviewed physicians who are opposed to medical aid in dying as a comparative? I mean, I found that when you kind of go to the opposite, the relief makes certain things stand out. Or it might be outside of the scope of your project. I'm not trying to make your project bigger than it already is.
I would say that's probably part of like a research agenda, but not this project for that. Thank you so much for your question. Yeah, and yes, I have. So but part of why is that I've in my own, like, what is interesting and what I want to study, and and we have, like, let's just pretend that we're not involved in that, but we are, like, we're, it's what we want to know about. I've been working, so a lot of palliative physicians, a lot of the opposition to it are palliative physicians. That's also a main concern that we didn't talk about. The notion that if medical aid in dying is passed, that it will take away from attention and funding, and then also that folks are only choosing medical aid in dying because they haven't gotten the right palliative or hospice care, right? And so I've been in those circles for a long time, and I've actually already heard a lot of that.
Okay.
So that isn't to say that I was researching or anything like that, but in terms of thinking about my own interests, like, I'm not going to pretend I'm not involved in that. So there's a certain extent to which it's, it's personal, and then there's this other extent to which, like, I need to get a dissertation done, and so it just wasn't part of the design of this, right? But I think that going forward, especially in unsettling autonomy, that would be really important, because that's a whole other, this isn't that, like, the physicians who are against it don't believe in autonomy, like, they're completely paternalistic, and then others, it's like how they practice autonomy, or how it manifests in their practice, it's different. So incredibly interesting. Didn't show up in this design and how I ask my research questions, and there's a little bit of personal reason behind that, but yeah, I think in terms of the full research agenda, it's an excellent question, excellent point.
Thank you.
Thank you.
Why don't we let Bruce have the last word? Last question. Bruce is still.
Hi there. I was just getting to unmute myself. I'm a philosopher, and our biggest enrolled course is ethical issues in healthcare. We have several sections of really large courses. I teach that course sometimes. We talk about differences between active and passive euthanasia and medical aid in dying, and we wonder whether there's really a moral difference between these three things. But I would also, as an empirical research, I think it'd be interesting to see what physicians think about, is there a moral difference? Do they think that maybe active euthanasia is most problematic, and then maybe passive, and then maybe least problematic is medical aid in dying? I just wonder, that's an empirical question, not a philosopher's question.
Yeah.
The final thing I was going to talk about is futility. I've actually talked to physicians about futility, and they have different understandings of futility. And I think it's interesting because it's kind of the flip side of autonomy. They're over, medicine kind of changed where what the doctor said was the way you're supposed to do things. And then patient autonomy became more important in the culture. And then I think people thought, gee, we have to put a break on this, because people think, well, I want more treatment, that's my choice, and you have to respect my autonomy. And people think, wait a second, there's something called fetal treatment, and we don't have to provide that. So I don't know that part of your research either, but it's kind of an interesting question what physicians think about futility because it does relate to autonomy. It's kind of the flip side. We got to brakes on this. Anyway, I thought two things might be empirical interest. Do physicians distinguish between active, passive, and mutual aid, medical aid in dying, and then the futility issue?
Yeah. No, I want to say that first of all, like futility, yes, like there are all these ethical principles and considerations that are huge in this, that might come out as we discuss more. Futility, beneficence. I mean, when that's a lot of one of the op-eds that I read is this neurologist who's talking about we're talking about doing no harm, and that's why folks are talking about why we can't provide medical aid in dying. But as a neurologist, my entire life, my entire career, I've been causing tons of pain. I've been causing suffering to folks, all in the interest of their healing or getting better. But sometimes the news is just that they're going to die, right? And so these different views on what doing no harm is. This is like what it is to do no harm, and a lot and then to answer your yes, that's an incredibly interesting question to ask, and I think that it varies quite a bit. Some folks are like palliative sedation; they see it as active involuntary euthanasia. And palliative sedation is when they, you provide, usually within days, sometimes weeks, that when symptoms are so very bad that a physician will medicate someone to unconsciousness. And the debate, whether this actually causes death sooner, how much sooner that death is, and in terms of thinking about where those sit, it's also complicated by how you define which one each of those are, right? And so both very interesting. Bioethics is in very much a part of my research and very interesting to talk about. So
I had a student write a dissertation on palliative sedation. What comes into the discussion is something called the doctrine of the double effect. And so people will say, well, okay, maybe it is causing death, but sometimes causing death is only foreseen as not intended. And that's a morally important distinction. So there are a lot of subtle issues, moral issues around this, but I was just thinking maybe there are some empirical ones that, that I don't know if you want to address, but could be addressed. How do they feel about the difference between euthanasia, et cetera?
Yeah.
That's not my concern. I just want to know, well, is there really a difference? But, you're doing a different study.
Definitely.
Thanks.
Yeah, thank you so much.
Jacqueline?
Yeah, well, if there are no more questions or comments, thank you all for coming. This talk has been recorded and will be posted on our YouTube channel so that you could refer to it just for future reference. I also wanted to put in there that our applications are open for next year if you wanted to give a brown bag talk yourself. Thank you so much, Caitlyn, for giving this very informative, very interesting talk today. The Humanity Center did want to thank you with gifting you with a caddy with our logo on it, and I don't have one with me, but a face mask as well that has our logo on it as well. Very fitting.
I'll wear it for my next talk.
Perfect.
Thank you so much, everyone.
Yeah, absolutely. And so yes, if you did want to apply for the Brown Bag Talks for next year, just send me an email at jboswell@wayne.edu. Dr. Edwards, was there anything else you wanted to say before we close out?
Thank you so much. I see somebody is clapping and I am clapping too. It is very informative. We all have to address these issues and to do it in a scholarly way and in a way that informs us as we get closer to that journey. Thank you so much for it. And I look forward to hearing the further results of your research when the dissertation is done and the book published. The Humanities Center can say that we were in some way helpful in providing you with ideas to finish your work. So thank you all.
Thank you, Dr. Edwards. Thank you, everyone. Thank you so much.
Thank you. Have a great rest of your day.